The Dermatology Education Foundation is hosting tonight's program. You can follow us on our website and of various social media platforms as well. And this evening, it is my pleasure to introduce our faculty. These are exemplary leaders in the MPA field in dermatology, as you may know. Wendy Cantrell from Birmingham, Alabama. Thank you, Wendy, for being here. Kara Gooding as well, a certified physician associate assistant from Scottsdale, Arizona, and Andrea Nguyen as well, another wonderful certified physician assistant associate as well from Irvine, California, and Joe Gorelick as well as a certified nurse practitioner from the Bay Area, as he likes to say. Joe is also the president and founder of the foundation as well. Welcome to all of you for joining tonight's program and of course sharing your experience, which there is a wealth of. Tonight's sponsor is UCB. I really love their tagline as well, this inspired by patients, driven by science. If you are not aware, UCB is a global biopharma company. They really have long demonstrated their commitment to dermatology NPs and PAs. And we're really excited that they are partnering with the Dermatology Education Foundation again. And this evening, we hope to give you a special glimpse into their clinical studies on Bimekizumab, as well as some real cases brought to you by this wonderful group of faculty and DEF Advisory Council members. For tonight's program, we will, of course, be hosting these special guests from the DEF leadership. They've prepared to share with you their own experience with treating patients with Bimekizumab, known to clinicians as Bimzelx. It is an IL-17A and IL-17F inhibitor biologic. It is approved for adults with moderate severe plaque psoriasis. And in addition to discussing their very profound head-to-head comparative trial data, it's become an integral part of making informed decisions about treatment selection, being able to have a glimpse into this type of data. UCB was prepared at launch in a way we have not seen in a long time, so we're excited to jump in and share this information with you. So without further ado, I'm going to turn it over to Joe Gorelick for tonight's program. If anyone has any questions, please note that you can enter those into the Q&A or the chat, and please be mindful as well for your information. The package insert for Bimzelx is found within that as well. Thank you, Joe.
Great, thank you, Stacy, and thank you, UCB. Super excited to be partnering with you again, and appreciate your recognition and support of dermatology-specific NPs and PAs. UCB is a company that's dedicated to immunology and to dermatology specifically in the United States. The United States is actually the only country that Bimzelx or Bimekizumab is new to, because it's been approved outside the United States for not just psoriasis, but also psoriatic arthritis for multiple years now. So it's great to have it. We got it back in October of last year with a wealth of knowledge with it coming to market, because it had been in play for several years. So what that gives us is a tremendous amount of data as we get our hands on it, not just efficacy data, but also safety data. That's so important because it gives us a level of appreciation in terms of how we can counsel our patients with regard to safety, but also what we may expect with respect to safety. In addition, the clinical trial data that we're going to look through has multiple head-to-head comparators, so we can make direct comparisons. So as you can see in the slide, there's almost 5,000 patient years of experience with Bimekizumab exposed patients. In dermatology, we're familiar with UCB and their offerings. The latest now is Bimekizumab, currently approved for patients that have moderate to severe psoriasis in the adult population, but also submitted, as you can see, to the FDA. They're pending approval for several other conditions, hidradenitis suppurativa, as well as psoriatic arthritis. You're familiar with other agents, an anti-TNF agent. Certolizumab has been available to us in the United States for both psoriatic arthritis and psoriasis in our space, but also outside of dermatology and rheumatology. It has multiple additional indications. one of the exciting things in the world of rheumatology also coming from UCB is their phase 3 study is ongoing with a systemic lupus erythematosus agent that's an anti-CD4 inhibitor. So as you can see, UCB is got a real pipeline and are going to be around to support nurse practitioners and PAs and patients in the United States with dermatologic and rheumatologic diseases. So Stacy gave us the label, Bimekizumab for moderate to severe patients with plaque psoriasis. The dosing is super straightforward. Each dose consists of 320 milligrams. That's 2 injections. So each dose is given at baseline. There's a dose, then there's 1 additional dose at 4 weeks, 8 weeks, 12 weeks, 16 weeks. So after that load, you go to every 8 weeks, unless you're over 120 kilograms. In that case, you can go every 4 weeks. So every 4 weeks to 16 weeks, then every 8 weeks for most of our patients. But in patients that are over 120, you have an option to go to every 4 weeks. So why are we here? You know, our understanding of immunology over the past 20 years has been on a logarithmic slope with the amount of data and understanding that's come to fruition for us. And so now we have a really great understanding of the pathways that are important in psoriasis. Initially, there were broader targets like TNF alpha inhibition and the Th1 pathway, but it's become very clear that the predominant pathway for psoriasis that drives this disease is a Th17 pathway. There's absolutely no doubt. So here you can see in purple, you have a naive dendritic cell that has been activated. When it becomes activated, it's activated under the influence of one of the primary key molecules that regulates the Th17 pathway. That's IL-23. IL-23 causes differentiation in the T cells, and those T cells then become specific to producing the chemical cytokine mediators that are driving inflammation. And the inflammatory mediators that are specific to psoriasis that are seen in highest concentrations are IL-17A and IL-17F. So the IL-17s don't roll by themselves. They pair up into dimers. So when you look at a plaque of psoriasis, you'll see IL-17A and IL-17F prevalently. But to cause inflammation and drive an inflammatory pathway, they have to be dimerized so they can bind to their receptor site extracellularly. And when that happens, and you have elevated levels of A and F, you have disease. And so the treatment of psoriasis is going to be aimed at decreasing these levels of elevated pro-inflammatory mediators. You can do this in lots of different ways. You can mop up or bind IL-17 directly. You could also block the receptor site, and those molecules are available commercially in the United States. And also, you can inhibit IL-23 activity and decrease the amount of IL-17 that's produced that way as well. One of the theories behind decreasing inflammation is mopping up IL-17 that comes from the IL-23 pathway, but also IL-17A and F are also produced independently from other sources. So in binding it directly, theoretically, you could mop up those additional sources as well. So here you can see the very specific mechanism of action that selectively targets IL-17A and IL-17F. So when targeting both A and F, you can mop up all the dimers that bind to the receptor sites that drive inflammation. If you target specifically just IL-17A, you'll miss the IL-FF homodimer. You'll mop up very well IL-17A homodimer and IL-17AF heterodimer, but there'll still be free-floating IL-17FF that can drive inflammation. So specific to the mechanism of action of Bimzelx, you're mopping up all 3 of these dimers, and decreasing the activation at that receptor site so you can decrease inflammation, as manifested in our patients with decreases in the level of disease. So we'll look at some clinical trials and look at measurements that quantify the reduction in their disease, the PASI scores. So a PASI 90 is representing a 90% reduction in the baseline PASI score. And what you're looking at here is 4 head-to-head trials with Bimzelx versus secukinumab in B-Radiant, where you have Bimzelx versus placebo in the B-Ready, and Bimzelx versus ustekinumab in the B-Vivid, and the B-Sure trial, you have Bimzelx versus adalimumab. When I look across all 3 of these individual trials, at just week 4, what I'm seeing is a very consistent ability of this particular agent to achieve a 90% reduction in the baseline PASI score. This is after 1 dose. If you think about PASI 90, a 90% reduction in baseline PASI score can be translated to a significant improvement in a patient's quality of life, which can unmask their ability to perform social functions, interact with friends, and go to work without having to hide their disease. It is a tremendous improvement, almost eliminating the disease. It's not completely clear, but PASI 90 is a very high bar. And it's nice to see across 4 separate trials, they have a consistent reduction of around 40%. This is after just 1 dose. So these patients were dosed at baseline, and then when you saw them back at the 1-month point, the 4-week point, they were achieving this 40% reduction plus in their PASI score. Let's take a look at what that looks like. So these pictures are courtesy of Alexa Hetzel, who's one of our advisory council members at the Dermatology Education Foundation. On the left, you can see the shin, the lower leg of this patient at baseline. It was covered with fine scale of psoriasis with a thick erythematous plaques. And then after 4 weeks, you can see a tiny bit of scale remaining, but the disease with respect to erythema, plaque elevation, the scale almost completely resolved. That's after just 1 dose. The second picture, a little bit fuzzy, but you can see the trunk having almost full resolution of the disease after 8 weeks. So what do these pictures mean? These pictures mean that when you see patients in clinic and they are talking to you about their disease and the impact it has on their quality of life and all of the things they've tried and failed through the years and their desire to get clear, the patients don't want to get just a little bit clear. They want to be all the way clear. They want to have as normal skin as possible, and they want it to happen as quickly as possible. And I think when you look at the PASI 90 numbers at week 4 and the PASI 100 numbers for this particular drug, it gives them an excellent chance at achieving their results. And you compare it head-to-head fashion versus secukinumab, ustekinumab, that are both very effective agents in psoriasis. You can see a direct head-to-head comparison at week 16, where Bimzelx demonstrated clear statistical superiority versus all of those agents at week 16. And again, the consistency between the trials, 85+% of patients had a 90% reduction in their baseline PASI score at week 16. The calculation of this data is done by the most stringent statistical analysis possible, which adds more credence and value to those numbers at week 16 via an NRI reduction. So let's talk about leveling up. Leveling up, we're talking about completely clear skin or a PASI 100. So this is at week 16. PASI 100 means when the clinical trial investigators looked at the patients and calculated all the different components that add up to a PASI score, there was no disease that was able to be evaluated. They had a 100% clear skin, a PASI 100, 100% resolution of their baseline PASI score. 60+% of patients across all 4 clinical trials versus their comparators achieved a PASI 100. We haven't seen these sort of numbers in clinical trials for psoriasis with any of the biologics. So 60% is the highest PASI 100 numbers that we've seen. So these elevated levels in the clinical trials are one thing. And one of the reasons we're here today is to share our real world experience with you for patients that we're seeing in clinics and seeing if this data matches what we're seeing in practice. And I think you'll be really excited, I know I am, to see the cases from Wendy, Kara, and from Andrea. So here you can see the comparative trial versus secukinumab, and I just want to focus on the PASI 100 one more time. After 4 doses at week 16, again, that 60% PASI 100 number. And then, as we all know, after a clinical trial endpoint of 16 weeks, psoriasis doesn't just go away. These patients have long-standing disease that are need to be treated for months and years and years and years. And so long-term data out to 1 year is what you're looking at here. And you had 67% of patients having a PASI 100 at the 1 year time point. So again, very high levels of 100% resolution in the baseline PASI score at the 1 year point. This is showing you, again, in a different trial, this is the Be Sure where you had, excuse me, Bimekizumab versus adalimumab. And you can see, again, at week 56, about 1 year, 60+%, 70% of patients achieving these high levels of clearance of a PASI 100. The point that this slide's making is that it doesn't matter whether patients continued on weekly dosing or after 16 weeks, as most patients will, you go to every 8-week dosing, the results are the same. And so most patients under 120 kilograms in the United States are going to go to every 8 weeks. And this data gives me credence that that's probably going to be enough to keep them clear. Yet the every 8-week dose did just as well. So that's available for our patients that are on the heavier side. So what about the package insert? This is a brand new biologic. You've got to do your homework. You got to read the label. Is there something different here? Do we need to change our behavior in prescribing Bimzelx versus prescribing the biologics that we have available before it? Actually, you do not. The package insert is incredibly clear. There's no black box warning. There are some callouts in the package insert that do not affect our prescribing or our monitoring. They talk about comorbid conditions that we see in our patients that have psoriasis, just like that we have discussions with our patients about comorbidities. And we're going to talk about those. Specifically, we'll talk about comorbidity for mood and depression, and also non-alcoholic fatty liver disease, which can result in psoriatic patients having elevated liver functions. So in the clinical trials, this is the label that's showing us the incidences of the adverse events of interest. And you see this across all of the biologics. And what we're looking for in a specific class, which is an IL-17 inhibition, is inflammatory bowel disease, such as ulcerative colitis and Crohn's disease. We know that at baseline, our psoriatic population has an increased risk at developing inflammatory bowel disease. So the IL-17 inhibitors in their label talks about potential risk for exacerbations or inducing it. So what we're looking at with respect to inflammatory bowel disease is we're looking for signals. And really what you can see here, very clean, low percentages for Bimzelx through the first 16 weeks, and in the long-term data, no elevation. Infections is a call out for all biologics prior to initiating therapy. We want to make sure our patients are healthy, and 0.3% of patients versus patients in placebo, and then all comers in the long-term 100-year data, very low incidence of serious infections. MACE events, again, very low, no signals here. Melanoma, non-melanoma skin cancers or malignancies, less than 1% in this patient population, very reassuring. no incidence of serious hypersensitivity reactions. And then this is an injection, so you do have injection site reaction, but it's very low, less than 3%. And then over 100 years, looking at that, it's less than 2%. So no new signals here, nothing that stands out at this, creating a behavior pattern that's different in prescribing this or monitoring for other patients, other than patients that have elevated levels of IL-17 in their system and have diseases manifested by that. When you modify or normalize the levels of IL-17, you can run the risk of creating opportunistic infections such as yeast infections, because there's a population of patients that do not have IL-17 and they cannot protect themselves from yeast, and they have to be chronically treated with antifungals. So there's a signal for Candida that's seen. So it's important to talk to all patients when you're initiating therapy about yeast, in particular thrush, and what to look out for. And if that happens, what do? I mean, we're in dermatology, we can handle thrush. In the standard practice would be to give them a prescription of fluconazole to take 100 or 200 milligrams a day for about a week, and that usually takes care of it. What they saw in the clinical trials was that the oral candidiasis rates were low. They usually happened within the first 16 weeks, and patients that had it were treated, did not discontinue therapy, and they didn't tend to have recurrences over time. So the events were one event in general per person, treated without patients discontinuing or other side effects. So it's a signal. We need to talk about it with our patients and be prepared to treat it if it's seen. Suicidal ideation is listed in the package insert. And remember, for our patients that have psoriasis, depression is one of the primary comorbidities of the disease. Also, in previous agents that are approved in the United States, the receptor blocker, an IL-17 receptor blocker, there were in the label suicides. And so in labels that we've seen that have come to market since that particular agent, it's likely that this will be a class warning. When you look at the suicides that were reported in this particular clinical trial, there was only one, and it was during the long-term extension at day 718. And it was very clearly adjudicated that this was not due to the medication. So it's in their label. You talk about it, make sure your patients know that it's in there, because they may go home and read it and say, hey, you didn't mention that. I'm on medication. I've had some issues with depression. So it's important to proactively bring it up, but it doesn't appear that this medication in any way is a causal agent for mood or specifically with suicide. And then in the label, there's also a mention of liver function testing. Well, I don't know about you guys, but I think all of us screen patients with a comprehensive metabolic panel prior to initiating therapy for psoriasis. And a lot of our patients with psoriasis at baseline actually do have elevated liver functions, because metabolic syndrome, non-alcoholic fatty liver disease appears to be a very high prevalence for patients that have psoriasis. And so likely this is what we're seeing with this call out for liver function tests. And it's a reminder, make sure you screen your patients prior to initiating therapy. But there's no call out and there's no required additional monitoring for liver function over time. So that's the important thing. And here is just data, and there's lots of data out there that talks about liver disease in psoriatic patients. And those of us that have been practicing before we had biologics, a lot of the agents we used to treat psoriasis were hepatotoxic, like methotrexate. So the patient population, the psoriatic patient population around the world has been evaluated, and there's no doubt that there's a higher incidence of non-alcoholic fatty liver disease prevalent. And it's actually been hypothesized by one of the articles you can see listed here on the bottom, that by treating patients with biologics, which are not hepatotoxic, that we may actually help decrease the inflammation in their system that leads to the systemic inflammatory progression of non-alcoholic fatty liver disease. So no requirement for liver disease monitoring over time. So these are pictures of our patients, the patients that we're seeing in the clinical trials here. You can see at baseline, this patient had a PASI score of 31.6. At baseline, had 61% of their body involved with psoriasis. After just one dose at week 4, when you look at this patient picture, you can see very clearly a resolution of the elevation from the plaque. The plaque elevation's gone. The scales are gone. You can see erythema and basically shadows where the disease was in this particular area. The patient had disease other parts of their body, so their PASI score was not completely reduced. But after 16 weeks and 4 doses, this patient had a complete resolution of their PASI score, PASI 100. And then you follow that same patient out to 52 weeks, they maintain that efficacy. This patient was on every 4 weeks based on their weight. Here you can see another patient from the Bimzelx, the Bimekizumab clinical trials at week 0. Patient essentially covered with disease. Look at the poor person's back. After just 1 dose at week 4, you can see that patient had a 75% reduction in their baseline PASI score. And at week 16, this patient also achieved a PASI 100. And then at week 48, almost 1 year, patient maintained that PASI 100 response. So what we're seeing here is sort of a trend of these patients achieving very high resolutions of their baseline PASI scores. So very excited to be joined now by our colleagues who are going to share some of their actual patients and their clinical practices with case studies. First up, we're going to be joined from Alabama by our friend and colleague, nurse practitioner with a PhD in nursing, Wendy Cantrell, to share her case with us.
Good evening. We were so excited to get Bimekizumab available for our patients. We knew that it was coming, and for several years, and we were seeing some of the early data. So it did seem like it took forever, but it was well worth the wait. And it has been super exciting. Like was said, is that we had so much data to share with our patients and to share with our colleagues. The head-to-head data is simply amazing, and it's just something we have not seen when a drug comes to trial. So I want to talk to you about a couple of patients that I have had on Bimzelx. First of all was a 54-year-old Hispanic male. He's a construction worker. He had psoriasis after a strep infection, after a viral illness in 2017. It was biopsy proven. It was guttate psoriasis, and it was less than 3% of his body. He really said that it was well managed with topical steroids until about 2019, and then it progressed to full-blown plaque psoriasis. I actually inherited this patient when I started in private practice in 2019. He had been on a Primolast, so he had been on a Tesla since 2020, and he was not well controlled, and he had the GI symptoms, and it really interfered with his work. The symptoms, he just could not have the GI side effects and be on a construction site. So we started him on secukinumab in 21. He cleared quickly within the first couple of months, but the psoriasis started returning after 6 months. And so in early 22, we divided that 2-injection dose of 300 milligrams that's typically done every 4 weeks. We divided it into 150 milligrams every 2 weeks. And that tends to work with some patients, in my experience, for those that it just doesn't keep them clear for that entire 4 weeks. And that worked okay with him for a little while, but in December of 23, his psoriasis just blew up again. It was impacting his work, he had significant plaques on his lower legs that when he would bend, that it would break, and it would be very, very painful because of the break in the plaques. So we started Bimzelx with him in January of 24, so just a couple of months ago. And I saw him about 4 to 5 weeks later, and he was 100% clear with just some, you can see here, I don't have before pictures, unfortunately, but he just had some post-inflammatory hyperpigmentation on his knees and lower extremities. He was very appreciative and very, very thankful. He said it was very, very quick. It just started, melting away after just a few days. So super excited. He was super excited. And, when we have a new medication, we always kind of hold he was actually my first patient to put on bimekizumab, and we kind of hold our breath, don't we, to see how quickly the patient assistance and how the bridge is going to work, and how well the patient assistance program is going to work. He got on drug very, very quickly. And you can see, I mean, just by the time he started in early January, and by February, he was clear. So he was able to be on drug and bridge very, very quickly. So super excited. He's super excited about his clear skin. And I'm going to share another patient with you. So this is a 31-year-old Caucasian female. She's morbidly obese. She's had psoriasis since she was a child, with a significant family history of psoriasis, which is what we see often, with our very severe psoriasis patients. She didn't have insurance. She didn't have insurance for many years. And so she would just get topical steroids when she could afford them. The thing that was most effective for her for the last several years was clobetasol. She didn't have severe psoriasis until after a COVID infection in August of 23. With that flare came significant joint pain, and she had when I saw her, she had a BSA of 50%. And it went from her scalp, it went from the tip of her head to her feet, scattered. She was tearful, she was depressed. She was desperate for relief. She said, I finally have insurance. I finally can have, some of these medicines I hear so much about on TV and in print. So we started the approval process for her, got her first dose in February. She said that she saw improvement within 24 hours. She said she took the dose in the evening, and she said by the time she woke up the next morning, she already felt better and her psoriasis was going away. By the time I saw her just a couple of weeks ago, she was 100% clear. I'm going to go back and let you see her elbow here again, and then you can just see how healthy looking her skin is. Just faint erythema there where those thicker plaques were. But she reports significant decreased joint pain. And I walked in the room, and she just had tears welling up in her eyes. And, she was just so thankful and so grateful that this medication worked for her. And she said she hadn't been clear in years. She hadn't felt confident in years because of the psoriasis that she had. So these two are two of the more impactful patients that I have on Bimzelx. And I would like to encourage everybody just to, when you see a patient, whether they are a multiple failure on other products or a brand new start, Bimzelx works really well. And I think UCB is doing a fantastic job with their patient support and their bridge program. We're able to get patients on medication very, very quickly. So reach out to your reps and be prepared to offer this treatment to your patients when you have an appropriate patient.
Wendy, thank you. Both of those cases were so impactful. We have all seen lots of cases, but still, I still kind of get the butterflies when I hear your stories, and we see these improvements. And what I love most about, I loved everything you said, but what resonated especially with me was that you said, don't reserve this for your train wreck patients just because it's new. Based on your interpretation of the data, and you're comfortable with the safety, your willingness to deploy it in all patients. I mean, why would you withhold an agent that appears to have a very clean safety profile, yet efficacy that we haven't appreciated to date with other agents makes so much sense. So thank you for sharing those.
Yeah, you're welcome.
Okay, so we have more to come. We are going to now be joined from Southern California by our colleague, our physician assistant, Andrea Nguyen, who's going to share one of her cases with us as well. So Andrea, thank you so much for taking time to join us. And we look.
Thank you so much, Joe, and thanks everyone for joining us this evening. I definitely second the sentiments that Joe and Wendy were just discussing, that Bimzelx is, I use it first line in cases as well as in patients who have tried and failed prior therapeutic agents. For tonight, for my cases, I am going to go over a few that have a little bit more extensive medical history as far as previously tried and failed treatments. I figured this would be a better topic for us to discuss rather than someone who is biologic naive. However, given the therapy and treatment efficacy and safety profile, I would feel comfortable starting in both biologic experienced and naive. Unfortunately, I don't have photographs for these cases. However, these are two patients that have I've been taking care of for some time, and both of them have a pretty interesting progression of their psoriasis. So my first case is a 28-year-old male that I've been seeing for a number of years now. He originally actually was told he possibly had lupus for his psoriatic plaques, the involvement that he had on his face. He came to us and we started treatment, established a diagnosis of psoriasis. He had some facial involvement, some scalp involvement, unfortunately some genital involvement as well, especially in the inguinal folds and then in his gluteal fold or gluteal cleft. And this, the private areas actually bother the patient much more so than some of the other areas, just because of the discomfort that he would feel associated with the inflammation there. We used a number of different topicals, including topical corticosteroids, hydrocortisone, triamcinolone, clobetasol to the scalp, and as well as some topical calcineurin inhibitors. We used tacrolimus and a vitamin D analog with calcipotriene. I've also used some advanced, newer topical therapies with this patient, tapinarof, topical roflumilast, as well as some phototherapy, apremilast, and ixekizumab. And even with a combination of some of these medications, using basically combination topical therapy with multiple classes of topicals, stepping through an oral apremilast for some time, the patient still was not clear. I advanced him from apremilast to ixekizumab, and even with ixekizumab and using combination topical therapeutic agents, I have him using tapinarof as well as steroids, roflumilast plus steroids, with alternating some frequency of dosing. He still had some of these sensitive areas of involvement really persistently in the inguinal fold, as well as on the facial lesions, actually. So we had 1% persistent BSA on the face and genitals, despite his most recent IL-17 inhibitor usage, as well as a combination of different schedule of topical usage. we discussed first starting Bimekizumab. He wanted to advance his therapy, obviously for his residual psoriatic plaques, and we switched therapies, showed him how to do the injections in office, and basically switched over from ixekizumab to bimekizumab or Bimzelx. At his 4-week follow-up, his BSA had started to improve, not really using much topicals anymore. The erythema was much improved, and basically the sensation of inflammation and irritation for the patient, though, was what significantly improved at the 4-week follow-up. At 8 weeks, there was just a little bit of residual erythema, not much psoriatic plaque, and he's not using any more phototherapy or topical treatments. And no adverse events with medication, doing well, really just on injectable therapy and not having to do any additional alternative treatment options in addition to his systemic. So this is nice, allows patients, this particular patient, to have less at-home treatments to do as far as applying creams, especially in some of those sensitive areas like the inguinal folds and the scrotum. Those are much harder to be consistent with just because of getting dressed, and typically sometimes humidity can be an issue for some patients in those areas. And now he's on pretty much monotherapy with systemic and Bimzelx only. Now, my second case is a 44-year-old female, a very nice patient of mine who has a long-term history of psoriasis. She also developed psoriatic arthritis. So 15 years history of psoriasis, developed psoriatic arthritis as well. She has her face, her scalp, her trunk, arms, legs, as well as her feet. So she has palmoplantar psoriasis and extensive involvement of her feet. When we were initially initiating treatment, she started out with about 14% body surface area. Similarly to our last case, she's been on numerous topicals, and these are in addition to systemic therapy. So she's been on multiple topical corticosteroids, as well as tacrolimus, a topical calcineurin inhibitor, vitamin D analog by itself, calcipotriene, as well as combination vitamin D analog, calcipotriene with betamethasone. I've also had her on tazarotene, as well as combination tazarotene with palibetasol, and some of the newer topical agents or advanced topicals with tapinarof and topical roflumilast. She has had phototherapy. We were starting with apremilast and then advancing to secukinumab and then to ixekizumab. And through each of these systemic agents, essentially, when she first started apremilast, that was to get her started. We were waiting for blood work, and essentially she wasn't controlled. We stepped through to an injectable agent with secukinumab, and on secukinumab she got better. Her BSA did improve significantly. However, she had some really persistent plaques, primarily in the scalp, very, very, very itchy, and even using secukinumab plus topicals, rotating through topical steroids and calcipotriene and some phototherapy, it was still persistent. So we fast stepped through to ixekizumab. So on ixekizumab, scalp was a little bit better. Plantar psoriasis is still there, was still present, and she basically was getting topical fatigue using topicals plus her injection therapy, and then we discussed advancing to brodalumab after some time. So she was on ixekizumab, and then we advanced to brodalumab. And again, with each of these additional changes, she gets a little bit more control, but really still having that persistent plaque on her scalp, and as well as the palmoplantar involvement of her feet, despite using topical steroids and these other alternative medications, including tapinarof and topical roflumilast. Once Bimzelx was approved, we talked about Bimzelx. She definitely wanted to switch, and we started her. I saw her 8 weeks after starting. The scalp was significantly better. She wasn't digging as much. She wasn't picking as much. Very scant residual erythema on the scalp. Plantar psoriasis, still a little bit of thickened skin on the bottoms of her feet, but essentially much improved and tolerating the medication very well without any adverse events.
That is, Andrea, thank you. The cases were both fantastic. And I would just say you are a true patient advocate, because instead of just settling with adding topicals and other things, you're constantly trying to give this patient the best quality skin that and the improvement in quality of life that they're looking for. So that's an awesome case. So without further ado, we're going to Kara Gooding from Arizona is going to share a couple additional cases with us.
Good evening, everybody. I would like to echo what Wendy said. When we see the psoriasis melting away in these patients, that has been my experience with the cases or the patients that I've started on the medication. And I also want to echo what Andrea said, where she said this should not be reserved for your patients that are train wrecks. You can certainly think of it as a first-line drug. They actually have some phenomenal data when you're thinking about, okay, what do I switch to? This patient has failed 1, 2, 3 biologics. They actually have some phenomenal data where they looked at that, and patients that have failed 1, 2, or 3 basically have the same efficacy outcomes as patients that are bio-naive, which we don't typically see that in other drugs. It's not until you get to 4 or more where you may see a slight compromise in the overall efficacy. So certainly a drug to think about in the vast majority of your psoriasis patients. So I'm going to share a couple of my cases, and I am going to say what Andrea said. I don't have any photos either, which I'm super disappointed about, but my first patient is a 58-year-old female. She has a history of psoriasis for about 15 years. She mainly had it on her scalp, her ears, and her elbows. And her past medical history was significant for osteoarthritis, hypercholesterolemia, hyperthyroidism, diverticulitis, and she'd also had a brain aneurysm. She's a non-smoker. She doesn't drink any alcohol, and her current medications were aspirin, turmeric, vitamin D3, levothyroxine, secukinumab, and clobetasol foam. She had no known drug allergies. She'd previously been on lots of topical medications, like patients who've had psoriasis for 15 years. They've cycled through many, many topicals. She had been on diproline ointment, clobetasol solution, clobetasol ointment. More recently, she had tried roflumilast cream, and she had previously been on Enbrel several years ago. She had been on secukinumab for about 3.5 years, and she was doing really well. Her psoriasis was completely clear. Of course, life happens. She had a lapse of her insurance, and she had restarted the secukinumab about 4 months prior to her visit with me. And unfortunately, she did not regain her same response that she'd had previously, and her scalp was driving her crazy. She was super itchy, and she had now some new larger plaques on her elbows as well. So she was interested in starting a new therapy. Her exam showed thick white plaque covering the vast majority of her scalp, covering the occipital scalp and the parietal scalp. And then she had some erythematous plaques with some thinner scale on the elbows. So her BSA at that time was 6%. Her itch was really substantial at an 8. And then she had moderate disease. So we discussed initiating a different biologic, and really what convinced me to prescribe the medication and the patient to want to go on the medication was I talked to her about the data that Joe had described, which is really the rapidity of the response that we see in patients, that we saw the patients achieving about 40% of patients achieving a PASI 90 at 4 weeks. 2/3 of patients can be completely clear by 16 weeks. So I did my biologic baseline labs. This is specific to what I do. This is not what's necessarily in the package insert. The only thing that's recommended is just the QuantiFERON Gold prior to initiation. But I also order a hepatitis B and hepatitis C panel. I live in Arizona where valley fever is endemic, so I check a Coxy titer. And then I also check if they are not seeing their PCP annually, I'll check a CMP CBC lipid panel as well. And again, the PI for Bimzelx does not require any ongoing monitoring. So after initiation, the patient followed up 4 weeks after her first dose. And she said that basically at about 10 days after her first dose, the psoriasis on her scalp had been completely clear. So she was a PASI 100 at 4 weeks. She was no longer using her clobetasol foam like all of our patients on biologics. That is their goal, is to not have to use any topical medication. And so she was very happy. And then I'll see her back after she's finished her initiation dosing, and I'll see her at week 16. And I would assume, based on the data that Joe presented, that she'll continue to be a PASI 100. So second case is a 44-year-old female. She had a 3-year history of psoriasis. Again, this is a scalp patient, but she had involvement on her face, her ears, her elbows, and her palms, so some very difficult to treat areas. Her past medical history was significant for anxiety, depression, hypercholesterolemia, and GERD. She did not have any arthritis, and she was currently on roflumilast cream, clobetasol solution, bupropion, escitalopram, methylphenidate, zolpidem, and drospirenone, which is birth control. She had no known allergies. So she had originally, when she first came to me, her psoriasis was pretty mild. We treated her with just some topical therapy. So she was on fluticasone cream. She used crisaborole ointment on her thinner skinned areas, clobetasol foam, and then she used salicylic acid 2% shampoo. She had a low BSA, but she was still very frustrated with her lack of improvement on topical therapies. So at that time, we started her on apremilast, but unfortunately, she had to discontinue after 2 months of therapy due to uncontrolled diarrhea. We then proceeded to put her on Gorelick, and due to significant worsening of her scalp psoriasis, that's why we initiated her. But after 6 months of therapy, she complained that she had lack of efficacy. She had stopped the medication, of course, didn't come in at 6 months. She just decided to stop the medication on her own and came to me 3 months later and said, I need to go on a different therapy. I'm frustrated. So this patient had psoriasiform plaques with micaceous scale on the scalp, the elbows, the palms, which were really significant. And then she had some patches on her upper eyelids. So her current BSA was an 8%, her NRS was 6, and she had moderate disease as well. So for her, because most importantly, we wanted to get her clear. She wanted to be clear. Of course, all of our psoriasis patients want to be clear yesterday, but due to the facial involvement, we needed something for her that we felt would get her clear very, very quickly. And so we decided to talk about Bimzelx. This patient does have a history of depression. Obviously, you saw the medication that she was on. So I discussed with her what's in the package insert. I went over it with her in depth, and her depression and anxiety had been very well controlled on medication. She felt very comfortable with proceeding. And so we were able to start her. I did my same lab work on her as well prior to initiation. And she came back into the clinic 4 weeks later. And again, after 1 dose, she said that her psoriasis was completely clear on her hands, her elbows, her scalp, her face. The only thing she said was that her dose was actually due the following day, and she was starting to get itchy again. So obviously we had her continue with her every 4-week dosing, and it'll be really interesting when she follows up to see, does she start to get a little itchy before that 4-week dose, or after going through the initiation dosing, will that stop? So I think that'll be an interesting thing to follow up on with this particular patient.
Fantastic case. How much does she weigh, Kara? Is she even a candidate for every 4-week dosing after 16?
She is not. No, she's of normal weight.
Yeah.
120 kilos.
So interesting too, that one slide I showed that regardless of weight in the clinical trials, they really saw that most people every 8 weeks was enough in the maintenance phase. So hopefully that's what we'll see in maybe a future Dermalorian webinar. We'll be able to see some longer term pictures for these patients, and hopefully they can get clear and stay clear. I heard a very consistent theme with all of your cases, and I feel the same way with this medication in my practice, is that patients have a lot of things going on in life, and today's world, we've got a lot of options, and I think it's important to sort of meet them where they are, and if we have opportunity to get them to PASI 100 or close in a very rapid time frame, then these are the agents I think we want to consider deploying. So thank you for sharing all of your clinical cases and sharing your clinical pearls and treatment strategies for these patients with psoriasis. It's great to have new options, and I'm excited for all of us to be able to help our patients with immune-mediated diseases, psoriasis, atopic dermatitis. As we all know, we anticipate the approval of Bimekizumab for HS and psoriatic arthritis in the coming months, if not year. And so great tool to have in our toolbox. We want to thank again UCB for their support and sponsorship of the education of NPs and PAs in dermatology. If you have additional questions, please enter them into the chat or put them in the Q&A. We will get to you, and we will respond to you directly via email at the conclusion of this program, unless we get a few more before the end, but we're kind of running up against the clock here. So again, a sincere thank you and appreciation to UCB for helping us take great care of our patients, providing us with data-inspired clinical trials and head-to-head trials, and being there to answer our questions for our patients as we're treating them. And I can't remember if it was Wendy or Andrea, but one of the biggest hurdles we have is access to these medications. And I heard that the access issue was not a hurdle at all with Bimzelx in one of your cases. And I can tell you from my practice, we have not had issues getting patients started. And I share the same sort of experiences and cases that you saw tonight with onset of action like we just have not seen for patients with moderate to severe psoriasis in levels of clearance after just one dose.